All right, welcome. Today, we're going to build a solid clinical framework for tackling airways disease. The goal here is to give you a guide that helps you confidently diagnose and manage these conditions, which, as you know, are incredibly common and can be pretty challenging.
So picture this scene. You've seen it a million times, right? A patient comes in with that classic trio: cough, wheeze, and shortness of breath. Your mind immediately starts racing. Is this asthma? Is it COPD? Or could it be something else entirely? Having a systematic approach is absolutely everything. So let's build one together, right now.
Okay, so from a bird's eye view, you're usually trying to figure out which of two heavyweights you're dealing with, asthma or COPD. And really, their typical stories couldn't be more different. Asthma, that usually kicks off when you're young, it's often driven by allergies, and the symptoms, they come and go. COPD, on the other hand, tends to show up later in life, almost always linked to smoking, and it's a slow, steady, progressive decline.
So here's our game plan. We're going to start with the basics, then walk through the whole diagnostic process. After that, we'll get into the nitty-gritty of managing both asthma and COPD, and we'll wrap up by looking at a few other conditions that can look suspiciously similar.
All right, let's jump right in. First things first, what is the core problem that actually connects all of these different diseases?
The common enemy in all of this is chronic inflammation. It's this inflammation that creates a triple threat inside the airways. First, the muscles around the airways tighten up. Second, the airway walls themselves get swollen with fluid. And third, the body starts pumping out way too much mucus. The end result is always the same. The pipes get narrower, and it becomes hard to breathe.
So, how do we get from just a hunch to a rock-solid diagnosis? Well, this is where the real detective work starts, and our most powerful tool, by far, is just listening to the patient's story.
A really detailed history it's everything. You gotta ask the right questions. Are symptoms worse at night? That classic diurnal variation really screams asthma. Is there a 40-pack-year smoking history? Well, now we're leaning hard towards COPD. Or here's a big one. Do their symptoms magically get better on the weekends, away from work? That's a massive clue for occupational asthma. Each answer helps you build your case.
After you get the story, you need some hard evidence. And that's where spirometry comes in. But remember, this isn't just a one-off measurement, it's a dynamic test. We get a baseline reading, then we give a bronchodilator, usually a SABA, to try and open up those airways. Then we measure again. It's this before and after comparison that really forms the cornerstone of our diagnosis.
And this is the deciding factor, right here. How do the airways respond? In asthma, that tight, smooth muscle is able to relax, and boom, we see a big improvement in airflow. That's what we call reversibility. But in COPD, a lot of the damage is structural, it's fixed. So even after the bronchodilator, the obstruction is still there, and that FEV1 over FVC ratio stubbornly stays below 0.7.
Now, once you've landed on that asthma diagnosis, your job isn't done, because you see, asthma isn't just one single thing. It's really a spectrum of different conditions, what we call phenotypes, and figuring out which type you're dealing with is the key to getting the treatment right.
This is the classic asthma pretty much everyone thinks of. It's driven by allergies in a specific inflammatory pathway called type 2 inflammation. The cool thing is, we can actually measure this with biomarkers, like looking for high eosinophil counts or IgE levels. And this is so important now, because these markers have become the targets for our newer biologic therapies.
And we also have to remember something called exercise-induced bronchoconstriction, or EIB. Now, this is super common in people who already have asthma, but, and this is key, it can also affect people who don't have chronic asthma at all. Think about elite winter athletes. The big trigger is often breathing in that cold, dry air during a really intense workout.
And please never, ever forget to ask a patient what they do for a living. Occupational asthma can be triggered by hundreds of things in the workplace. It could be flour dust for a baker or chemicals for a factory worker. That classic story of feeling better on weekends or on vacation, that's the dead giveaway.
Okay, let's talk about a huge shift in how we manage asthma. For decades, if you had mild asthma, you just got a blue reliever inhaler. That's it. But the latest GINA guidelines have completely changed the game. Now, the recommendation is to use a single inhaler that has both an inhaled corticosteroid and a long-acting bronchodilator, like formoterol, for both daily control and for quick relief. The logic here is brilliant. It ensures that every single time a patient reaches for their reliever, they're also getting a dose of anti-inflammatory medicine. It directly tackles the underlying problem.
Now let's switch gears to COPD. With COPD, the focus is different.
We're managing a progressive disease, trying to reduce symptoms, and most importantly, prevent those flare-ups or exacerbations that cause so much harm and land people in the hospital.
You know, when we assess COPD, just looking at the FEV1 from spirometry only gives you part of the picture. Sure, it tells you about airflow, but it doesn't capture how the disease is affecting the entire body. That's why the BODE index is such a powerful tool. It brings in body mass index for nutrition, obstruction from the FEV1, dyspnea for symptoms, and exercise capacity. It gives us a much richer, more holistic view of the patient, and it's way better at predicting things like hospitalizations and mortality.
The GOLD guidelines give us a really clear way to start treatment. It's all based on two things: how bad are their symptoms, and what's their risk for future flare-ups. So, if someone has low symptoms and low risk, we can start simple with just one bronchodilator. But for patients with worse symptoms or a history of exacerbations, we get more aggressive, quickly moving to dual therapy with a LAMA and a LABA. And if they have high eosinophil counts, sound familiar, we might even add an inhaled steroid, borrowing a page from the asthma playbook.
And this brings us to the most important thing on the screen, the absolute #1 most critical intervention for anyone with COPD. Our inhalers are great for managing symptoms day to day, but quitting smoking is the only thing that has ever been proven to actually change the course of the disease and slow down the damage to the lungs. Every single visit is a chance to talk about this.
Okay, to wrap things up, we know asthma and COPD are the usual suspects, but you always have to keep a broad differential. So let's just quickly touch on two other important conditions that can fool you.
You should think about bronchiectasis whenever you have a patient with a chronic, productive cough, often with nasty-looking phlegm, and a history of getting pneumonia over and over again. The core problem here is that the airways have been permanently damaged and widened, and they basically become a perfect breeding ground for bacteria.
And you don't diagnose this with breathing tests, you diagnose it with pictures. A high-resolution CT scan of the chest will show you these classic signs. See how the airway is now bigger than the blood vessel right next to it? That's the classic signet ring sign. And you can also see how the airways just don't get smaller as they go out toward the edges of the lung like they're supposed to.
And finally, please remember that cystic fibrosis is not just a disease of childhood anymore. We're diagnosing more and more patients as adults. So if you have an adult patient with bronchiectasis, especially if they also have chronic sinus problems or GI issues, you have to think about CF. And here's a key clinical pearl. A negative sweat test in an adult absolutely does not rule it out.
Which brings us to our final thought. Look, airways disease can feel overwhelming, but having a structured approach, starting with a careful history, using spirometry to understand the physiology, and then tailoring your therapy to the specific diagnosis and phenotype, that is, without a doubt, our most powerful tool for improving the lives of our patients.